Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of Graves' disease. Dr. Travis Brown, me, of course, not being a doctor, when I hear Graves' disease, I think you're taking us back to the grave robbing days of, what was the 1800s or thereabouts?
Actually, it's interesting. It takes me back to, I remember sitting in a lecture theatre with an endocrinologist who was the dean of the school at one time, and he said, one time I diagnosed a patient with Graves' disease, and she got incredibly upset when she went home, came back the next week, because she thought she was talking about Graves' disease as in dying, as opposed to Graves' disease as in after Robert Graves. So that's a bit of a learning. That story stuck in my head, as you can imagine. But yes, we're talking about Graves' disease. So this is the most common cause of hyperthyroidism. And look, sometimes, I love stories of medicine. I always love stories of medicine, but sometimes I get to handball the story off. And this is one of those instances. We've actually got Liam, who's a doctor from Perth, who's written a book, and he actually discusses these, sort of giants of medicine, but we have the names such as Robert Graves, but we know as Graves' disease. And so I get to hand it off to say, okay, tell us about this remarkable person, and where did this name of the disease come from? How did we learn about this, and how did it all come about?
And of course, with Liam, of course, being Irish and Graves being Irish, there's 1 or 2 degrees of separation between him and Oscar Wilde. So that continues.
It does. And this is the amazing thing, you realize how small the medical world sometimes is and who we learned from. And this is a man who's a giant in medicine. And then you start to narrow it down in Ireland and all these amazing kind of links. So yes, it is one of those ones where we look at and just find out about a remarkable story about a remarkable man.
Dr. Liam Mulcahy is a doctor who moved from Ireland to Perth, Western Australia, in 2022. He's a degree with first-class honours in neuroscience and studied medicine at University College Cork. Liam's got a strong interest in neurology, particularly stroke medicine, and is currently undertaking physician training. He enjoys writing and storytelling, both fiction and non-fiction. And his latest book took 2 years to write. It's called Beyond the White Coat, that explores the people behind well-known medical names, and it's available on Amazon. We'll put a link in the show notes. We're discussing one of the chapters from his book called Irish Charm about Robert Graves, revealing the fascinating story behind the condition, Graves' disease, that bears his name. Liam, welcome to This Medical Life.
Thank you for having me.
Can you start by telling us about Robert Graves? What sort of student was he? What did he get up to?
Yeah, so Robert Graves, he's one of my favorite individuals I wrote about because he's had a fascinating life long before he discovered Graves' disease. So to give context, he was born in 1796. So we're talking about the early 19th century era, a time when medicine was still evolving. And he grew up in an academic Irish household, surrounded by books, lively discussions. And that curiosity really defined him from the start. And as a student, he had a wide-ranging interest. He loved literature, painting, languages. And one of his tutors actually was the uncle of Oscar Wilde, the well-known Irish author and poet. So that gives you a sense of the cultural influence he had around him. And then at Trinity College Dublin, he excelled academically, becoming known for quoting the classics and speaking Latin and Greek almost naturally as English. And he graduated, unsurprisingly, with top honours. And he was physically hard to ignore because he was tall, he was broad-shouldered, dark hair, and his eyes were always sharp, full of fire. And he had a deep Irish voice, which carried, both warmth and authority. And of course, people were naturally drawn to him instantly. And then after he graduated medicine, he traveled extensively across Europe. He wanted to broaden his knowledge, his horizons. So he'd been to places like London, Edinburgh, Berlin, Vienna, Paris. And these journeys helped him build connections with leading physicians and thinkers and exposed them to new ideas about clinical practice. So when he eventually returned home to Ireland, he wanted to use what he learned to challenge the older, more rigid traditions he saw around him. And he was almost becoming a disruptor within the Irish medical community.
Now, you mentioned, of course, the link to Oscar Wilde's family. Of course, he would have predated Oscar, but Oscar's father was a surgeon who operated out of their home. Does everyone in Ireland in that particular time have some sort of link to the world of medicine?
I think it appears so, based on what I've been reading.
Now, there is some interesting aspects to his time before he sort of became famous from our perspective, where he was actually arrested for being a spy and almost died, almost died in a boating accident. Can you tell us how that happened?
This is one of my favorite parts of his story. So when he was traveling through Austria at the time, he was on his own, and the Austrian soldiers thought he looked suspicious, so they stopped him. And they were asking for papers, and he didn't have any passports on him, but he could speak German. So he explained, I'm just passing through, I'm not any trouble here. But he was so fluent in German that they weren't convinced that an Irishman could speak so clearly in German. So that heightened their suspicion, and they arrested him. And they ended up imprisoning him for about 10 days with lack of food. He was in horrible conditions, and he became weaker, lost a lot of weight, and he became quite unwell. And when they cleared him after 10 days, he just wasn't back to his full health afterwards. So not shortly afterwards became the dramatic episode where he was on a small brig which is bound for Sicily. And he was in his cabin at the time. There was only 2 passengers, him and his a Spaniard companion that was with him, and then the rest of the crew. And they were going through a horrific storm at the time. And his companion charges into the room saying, the crew are abandoning the ship, and they said we're to be left behind on the brig, panicking. And whatever strength he had, he got up and he put on his coat, and there was an axe in the corner of the room. He picked that up just in case. And he went out, and outside he just saw chaos on the deck. The crew were putting together the only lifeboat that was there, and he said, "Stop! The lifeboat is not going to survive those stormy seas. It's best to stay on." And the captain dismissed him. He said, "No, we're going. You stay here." And he said one of my favorite quotes that he documented when he was reflecting on this. He said, "If we are to be left behind, then let us all be drowned together. It's a pity to part good company." And after he said that, he got the axe and started hacking the lifeboat, the only lifeboat, until it was completely destroyed. And the captain, seeing this, almost pulled out his dagger, but he stopped because there was something about him that he was like, okay, this guy is different. And then Graves took the opportunity and took control of the whole ship. So he urged the crew to act quickly, organised the pumping of water, repairs to the damaged hull, and worked along them through the night. Gradually, the ship stabilised, and then by dawn, the storm passed, and the brig limped onward towards Sicily. So the crew were now looking at the stranger with a mixture of relief and respect. And why it's my favourite story, it just shows long before he became the famous physician, Graves already had that instinct to step forward, take responsibility, and lead when lives were at stake.
That means he was a spy. Surely that's the sort of training James Bond would have.
Well, we don't know.
Yeah. Now, his approach to medicine and teaching was quite revolutionary. Can you tell us a little bit about that?
Yeah, so after he returned from his travels and he was just settling back in Ireland, he began working at Meath Hospital in Dublin. And that was one of the major teaching hospitals at the time. And to give context, medical teaching was very formal. The students often stood at the back of the wards, listening but not really participating. And Graves didn't like that. He wanted to change this. And this is where his travels really began to influence how he practiced. So on the ward rounds, he would call them forward, ask them to examine patients themselves, discuss symptoms, and think through the diagnosis together. Some colleagues were uneasy with this new style, but Graves believed, learning through direct observation. Over time, his approach began to spread and helped shape modern clinical teaching.
It's kind of strange how we sort of look back. This is a few hundred years and this is revolutionary and this is the only way we'd sort of do things, which is incredible. But he also had the theory of the time was starving a fever. So people who wouldn't have something like if you had a fever, you wouldn't give them food or nutrients because you needed to starve out. How was his approach different to that?
Yeah, absolutely. You summarized it quite well there, that they believed that, nourishing the patient would feed the fever, they make the fever worse. But he was very observant and he thought that patient became dangerously weakened. Now, it's not documented, but I also think his experience of the imprisonment for 10 days and not eating and becoming weaker probably played a role in his decision-making. So trusting his clinical observation rather than the old tradition, he began offering small amounts of simple nourishment. And then he noted that the patients were recovering in their strength, and then they had better outcomes. And he later joked saying, if you were to be remembered for anything, he'd hope his epitaph would simply read, "He fed fevers."
And so Robert Graves is best known for his condition we now know as Graves' disease. So that's hyperthyroidism, caused by, again, antibodies that we discussed a little bit later. But how did he first recognize this condition?
Yeah, so what's fascinating is that Graves didn't initially understand the underlying cause. He wasn't thinking in terms of, hormones or autoimmune disease. That knowledge comes much later. So what he did notice was a consistent pattern of symptoms at the bedside. And he observed that patient presenting with a striking triad of features, such as the enlargement of the thyroid gland, the prominence of the eyes bulging, and that persistent rapid pulse, often accompanied by tremor and nervous agitation. And over time, as more cases appeared, he realized these features were a constellation of a distinct clinical syndrome. So he discussed his observations with colleagues, compared cases, and eventually he presented his findings formally. And this is a classic example of, the diagnosis emerging from careful bedside observation rather than through laboratory science.
So how did Graves then, how did we get the name Graves' disease? Where did that come from?
He wasn't the only physician to describe this condition, interestingly. So there had been earlier observations a few decades before him, one made by Caleb Hillier Parry, but his findings were published after his death. And there was a German physician by the name Karl von Baestow, and he independently described similar cases, which is why the condition is still called Baestow's disease in parts of Europe. So Graves, however, he had a strong international reputation and professional networks built during his travels. And this helped his description gain wide recognition. And the influential French physician Armand Trousseau, who admired him, helped popularize the term Graves' disease. And that became the name that eventually stuck in much of the English-speaking world. And it's interesting that differing terminology reflects how medical eponyms often spread through professional influence and cultural exchange.
Within Ireland itself, is Graves well known as table conversation, or is it really in the rarefied fields of medicine?
I think from my experience going to med school, because he is down as being a member of the Irish College of Physicians, but I don't think a lot of people are aware of the life that he led, and that we know that there's a condition named after him, but I think that's as much as we know about him. The whole life that he built beforehand, when I asked my colleagues, especially back in Ireland, they were shocked when I told them that he hacked a lifeboat up in order to save a ship, and they were like, "That makes no sense." So his private life was definitely not well known, but and I think a lot of people are not probably as aware of how he came about the disease. We just take it for granted. This condition is named this. We don't really ask beyond that.
Yeah. One thing that struck me while I was reading your book was the personal tragedies that Robert had, which again almost boggles the mind. Can you tell us a little bit about that?
Yeah, so a lot of his life was markedly profound by loss. So when shortly after he arrived back to Ireland in 1821, he married Matilda Jane Eustace, and even though the marriage brought happiness, it was short-lived. She died soon after childbirth, and their infant daughter also passed away. And this was tough for him. He was grieving quite for some time, and he married again in 1826, several years later, to Sarah Jane Brinkley. And tragically, within a year, she too died in childbirth along with their infant daughter. And this repeated bereavements and had a profound effect on him. And rather than withdraw, he channeled his grief to his work, devoting himself more intensely to medicine and teaching. And this later portraits of him actually captured this change. His once animated features appeared heavier. That spark he once had in his eyes seemed dull, and just suggesting how deeply these experiences had affected him. However, it wasn't all doom and gloom. He eventually found stability in a third marriage to Anna Grogan, whom he had 6 children with, and she outlived him by 2 decades. So that was probably the only light and family happiness that he had after years of hardship.
Yeah, it's just incredible. I'm sort of like, childbirth and everything like that, just looking back at the statistics is just incredible. It's amazing that he was actually able to keep on teaching and have the passion and the medicine and the everything that was going through. But I mean, from your perspective, having studied him, what do you think the legacy that Robert Graves would have liked to have left with us or with doctors or with medical students?
I think his greatest legacy is really the way he reshaped clinical teaching and patient care. He really championed bedside learning, encouraged independent thinking, and emphasized treating patients as people rather than just cases. So in many ways, this approach feels very modern, as you said. Today, we talk about patient-centered care and clinical reasoning at the bedside, all ideas that Graves was advocating nearly 2 centuries ago. So while his name, lives on in endocrinology as Graves' disease, I think his influence is felt every day in hospital wards and medical schools around the world.
He is quite an enigma. Thank you for that look into his life, because the way he started that ward circulation, we wouldn't have programs like House were it not for that. And although I thought, no, he's got a kinder heart. But then you think of him smashing up the lifeboat. That is very House.
Yeah. He's yes, House is a modern Robert Graveson.
Yes,
Yeah.
I'll pay that. Dr. Leo McCaughey, thank you very much for joining us on This Medical Life.
Thank you for having me.
Professor Duncan Topliss is a senior endocrinologist in the Department of Endocrinology and Diabetes at the Alfred Hospital, Melbourne, and Professor of Medicine in the Department of Medicine, Monash University, Melbourne, Australia. He's a past president and life member of the Endocrine Society of Australia. He's been involved with the development and implementation of clinical practice guidelines for diabetes and other endocrine diseases at the local level over many years. He served on the editorial board of Clinical Endocrinology and is a frequent reviewer for Clinical Endocrinology, the Journal of Clinical Endocrinology and Metabolism, Thyroid, and other endocrine journals. Duncan's a returning guest on This Medical Life podcast. Duncan, welcome back.
Thank you very much.
Duncan, how common is Graves' disease?
It's a common endocrine disease. The prevalence of hyperthyroidism, of which Graves' disease is about 70%, is about 1.3% of the population. About 0.5% is overt. There's a proportion that are subclinical. So in the incidence of hyperthyroidism varies in different studies, but 16 up to 80 per 100,000 per year in women. So the lifetime risk for women is about 3%, and for men it's only about 0.5%. So it's more common in women than men, but it's a common condition in particularly adult women. much less common, but not at all unheard of in children.
Do we understand the pathogenesis of this condition?
Well, it might help first to just briefly describe the physiology. The thyroid is a factory for making thyroid hormones secreted into the bloodstream, and that is regulated by thyroid-stimulating hormone acting on the cells, on receptors on the surface of the thyroid cell. TSH, thyroid-stimulating hormone, comes from the pituitary, it's a glycoprotein hormone, and it stimulates both the synthesis and release of thyroid hormone. And the pituitary functions as the feedback of thyroid hormone by sensing the level of thyroid hormone in the blood and either increasing or decreasing TSH level to maintain the normal range. So, of course, this is finely regulated to maintain a smooth, normal range. Now, with Graves' disease, there's an intruder in this, and that's thyroid-stimulating immunoglobulin or thyroid receptor antibody. And this acts on the TSH receptor on the thyroid cell to stimulate, like TSH does, but it's a more prolonged stimulation, and it's not subject to the normal feedback. So it's basically a product of how many cells there are making the antibody and how potent the antibody is, and it's an immune problem. And so it's completely will overdrive the thyroid, and even though pituitary TSH will be suppressed in that, it doesn't influence the overactivity because that's being driven by the antibody. So the pathogenesis is that it's an autoimmune disease with this specific antibody or antibodies which drive thyroid overactivity.
What are the risk factors for developing Graves' disease?
Risk factors you can't do much about. Being female is about 5 or 6 to 1 versus male. There's clearly a genetic predisposition, so you can get a handle on this by asking about family history. Pregnancy, particularly the first trimester and the postpartum, where there are immune changes, can induce hyperthyroidism in people who are otherwise susceptible. Smoking is bad for the thyroid, and so it can provoke or make Graves' hyperthyroidism worse. Iodine is an essential micronutrient, but excessive iodine intake, particularly in people who are susceptible, can trigger overactive thyroid. So excessive iodine supplementation, drugs containing iodine, and in a public health sense, we know that environmental iodine exposure variation can influence the rate of recurrence of Graves' hyperthyroidism. So that's another factor. And in more recent years, there's always been drugs that provide iodine excessively, but in recent years we've had immune stimulant drugs which have introduced and are very important in the treatment of metastatic melanoma. That's where they're first introduced, but they're now being used in a variety of other cancers. And these agents improve immune response to destroy cancer, but they can also provoke immune-mediated diseases such as Graves' hyperthyroidism. And there's also a drug which is being used in the treatment of relapsing remitting multiple sclerosis, which could also have the same thing. And then the other thing is the perennial question of, does stress have a role? And that's a subject that sort of would be a whole lecture on that, which we're obviously not going to do. But I think that ever since Graves' disease was first described and recognised, people have postulated on the possibility of stress. And in fact, when you look at the literature, there's studies which claim an effect, others which don't find an effect. Very difficult to know. It's a medico-legal question. I mean, the problem is clinically that people are stressed, but are they stressed because they developed hyperthyroidism and didn't realise they had it? So they say, I was stressed and then I was diagnosed. But is it because they had they were already suffering in the first place? Not so. I mean, you can invent mechanisms, psycho-neuro-immunological mechanisms, and I can't say they're wrong. I tend to sort of be a bit sceptical about it, but I can't dismiss the possibility of stress being a risk factor for the development of immune disease and Graves' disease. Yeah.
Duncan, in this medical life, we cover all sorts of diseases and conditions. Many of them are asymptomatic, but I imagine this is not one of them. What are the telltale signs, the symptoms that patients experience with Graves' disease?
Yes. Well, of course, there is a range, and so it can be quite subtle, but basically, heat intolerance, people feeling hotter than normal. I mean, in the hyperthyroidism, there's a generation of excessive metabolism, and there is some degree of heat generation, so the body, you can sense that. People tend to perspire excessively. The heart is speeded up, so tachycardia and arrhythmias sometimes. People feel tired or get tired easily. The effects can make you anxious and irritable. Spouse or partner often complains about that even more. There's weight loss because, of course, if you're consuming energy and you're not replacing it enough, then you tend to lose weight. And, of course, the weight loss can be fat, which people might like to get rid of, but it's also muscle as well, and sometimes heart muscle, and that's not so good. And so there is muscular weakness. So people experience muscular weakness, particularly around the shoulders and hip girdle, so they have difficulty lifting things over their head or getting up from a chair if it's profound, etc. But I mean, in a young woman who's otherwise fit, people say, well, I'm going to engage in the gym and I'm worse than I was, or I'm not able to do what I was before because of weakness. And then the other thing is, which is sort of a more of a neuromuscular etiology, is fine tremor. So people do notice a shake and tremor, which of course can be quite embarrassing. In women, they can have oligo or amenorrhea develop. And in chronic disease, then bone loss, osteopenia, osteoporosis can develop, and so there is an increased fracture risk, more seen in the elderly, as you might imagine. And then there are symptoms and signs related to the immune effects. So in Graves' disease, we think specifically of Graves' ophthalmopathy or thyroid eye disease, TED, as it's more commonly known, and so that's manifest as soreness, photophobia, stare, and what can be called exophthalmos or proptosis, and they can get double vision. And then there is much less common in the skin changes. There is a condition of Graves' dermopathy, what used to be, still can be called pre-tibial myxedema, not referring to the metabolic state, but to the actual appearance of the skin in that area. That's pretty uncommon, though.
Duncan, the first 2/3 of those symptoms fall in the category that I would dismiss as the stuff of life and easily just tolerated by patients. How does it get caught? Is it a patient hits a certain tipping point, or is a GP going to notice something in routine testing checkups?
Yeah, sure. Well, I guess when people at some point with all diseases, you reach a stage where you say, no, this isn't right. There's something wrong with me. And of course, what you hope, and then by and large, GPs are pretty good at suspecting thyroid disease and testing for it. So, I mean, people always complain, oh, it was missed, but there's an awful lot of people that get diagnosed properly and treated properly. So there's a lot of testing for thyroid disease. And so it is picked up pretty well. And these, I think most GPs are pretty attuned to this, and they rule out thyroid disease in people presenting with these things. So there's a lot of tests that are normal to rule out thyroid disease, but of course sometimes it does pick up genuine thyroid disease. So I think it does rely upon the patient saying, no, there's something not right here, and the GP thinking, well, I better rule out thyroid disease, or no, I'm pretty confident talking to them and looking at them, that's what they've got. So of course, it can be missed, but I think there's a lot of people being diagnosed and treated for overactive thyroid appropriately.
There is the term thyrotoxic. Is that a clinical kind of description? What's the difference between hyperthyroidism and thyrotoxic? Like, is that isn't it an assessment?
It's not a real difference. I mean, in the 19th century, thyroid hormones were not known, really. It was only at the very end of the 19th century, early 20th century, that the concept of a hormone, a small chemical being secreted somewhere and acting on the rest of the body, was first mooted. And so for the description of Graves' disease, 1835 through to 1900, people just said, well, there's something that's making the body unwell, and it's something to do with the thyroid because it's big, so they're toxic because of the thyroid. So it was a sort of and they still use the term thyrotoxic. some people draw a distinction between thyrotoxic, meaning it's the effect of excessive thyroid hormone, and hyperthyroidism, meaning it's due to overactive thyroid. I mean, there's very little difference, but occasionally, of course, people are taking excessive thyroid hormone. Or if the thyroid is inflamed and leaking thyroid hormone, as in a thyroiditis, then it's a little bit different. But in truth, it's just an old-fashioned term which still exists, um, and it's used almost interchangeably, really.
Is there such a thing as intermittent Graves' disease?
Oh, very much so. Graves' disease, like many autoimmune diseases, is characteristically remitting and relapsing. So about 50% of people that get Graves only have one episode, but other people will have repeated episodes. So it can be provoked, pregnancy, postpartum, being one of the classic circumstances. Sometimes we don't know why it comes back. I mean, this clone of cells expands, makes a lot of antibody, and then things, for reasons we're not sure of, like in the other autoimmune disease, it will settle down and the amount of antibody goes away. But there's always memory cells that can get reactivated, I think, and so people can have recurrences throughout life, and it's one of the issues as to the problem with this condition. I see people, not infrequently, who've had 5, 10 years of disease, and it's relapsing, remitting. They get put on tablets, it gets better, they get taken off the tablets, it's back again, and they come along and they're absolutely fed up with this. It's interfering with their life, etc. And a lot of my discussion with these people to talk about the nature of the condition, but to suggest we've got to cut the Gordian knot on this, that it's disrupting your life, and maybe the best plan is to have, as we're going to talk about later on, some form of ablative therapy to deal with the condition. So it is relapsing and remitting, but not everybody will relapse. So we don't necessarily want to knock out the thyroid irreversibly first time we see this condition, because many people will recover and won't have persistent problems.
Now, you mentioned that there is hyperthyroidism, 70% is Graves' disease. What's the other conditions that can cause hyperthyroidism?
Yeah. Well, the big four, as I teach my medical students, are Graves' disease, toxic multinodular goiter, there's that word toxic again, thyrotoxic, an autonomously functioning thyroid nodule, which is a benign thyroid adenoma, which can oversecrete. Most of them don't, but some do, and a condition which is self-limiting subacute thyroiditis. Those are the sort of the big four: Graves, multinodular goiter, toxic, autonomous nodule, and subacute thyroiditis. Then there's a whole range of much less common things. I mean, the vast majority of people that have hyperthyroidism, it's not due to the pituitary, but there are rarely TSH secreting pituitary tumours. And occasionally people could have relative degree of thyroid resistance. So that would think, well, why would they be thyrotoxic or hyperthyroid? But the answer is that sometimes different tissues have different susceptibilities. And those conditions can be genetic, inherited as a familial association. And it's important to recognize those. I mean, the clue to those ones is the TSH level in the blood test is not suppressed. So when a doctor GP does the test and the TSH is not very low, they should think there's something odd going on here, and that's where particularly the endocrinologist needs to be involved to try and sort that out. But they're really quite rare.
How common is the eye conditions? Everyone's actually probably familiar with opening up the book where you actually see the patient just staring at you with these massive eyes type thing. It's a classic picture. But how common is that now?
Yeah. Well, look, that severity of disease is not common. It's maybe less than 5% of people with Graves' disease are at risk of getting severe eye disease. It usually develops right early on, so it can be part of the initial presentation of the immune problem with the overactive thyroid. But it depends on how hard you look. If you look for subtle problems, 50% of people with Graves' disease may have changes in the musculature or the tissues of the orbit, because it's not the eyeball that's the problem, it's the tissues of the orbit, the muscles and the fatty tissue in the orbit. And so you can detect that on, say, MRI scan, and you can maybe, if you in a research setting, you can find antibodies that might be involved with that. But only 3 to 5% of people have severe disease. And it's a very distressing condition psychologically, and of course it can be, when it's very severe, it can be a threat to vision. I mean, even mild diseases can be very upsetting for people, because even subtle disease, you're looking at the mirror and you're seeing your eyes are not symmetrical or something like that. So it can be very worrying. So what we would think of as medically trivial can be psychologically, personally very disturbing. So I have a pretty low threshold of getting opinion from ophthalmologists, oculoplastic surgeons who are interested in this area, because these problems can be helped now a lot more than they used to be by ophthalmologists who have skills in this particular area, and people's lives can be made a lot more comfortable and a lot happier with themselves if these things are addressed and taken seriously. But severe eye disease is uncommon. I wouldn't say rare, but there are many ophthalmologists now with expertise in this area.
Now, is testing for TFTs and thyroid receptor antibodies enough to diagnose Graves' disease?
Well, certainly biochemically, that's right. I mean, you look for a raised T4, sometimes and T3, sometimes it's only T3, which is usually milder disease. You look for suppression of TSH, should be right low, less than 0.02 milliunit per litre. And with positive TSH receptor antibodies, a very strong case. As in all medicine, you want to see, you'd like to see some clinical correlate so you feel comfortable. I mean, if you've got biochemistry and nothing else, you should be a little bit suspicious, but in principle, yes, that's what you need. So you look for, of course, a smooth goiter, you look for subtle eye signs, and you make quite sure, as I said, that the TSH is suppressed. Just occasionally when you're not certain, then I think a nuclear thyroid scan is very good. If you've got a thyroid which you think could have a lump in it, the thyroid's a bit tender, sometimes even in Graves' disease, although it's not a thyroiditis, like subacute thyroiditis, the gland can be a little bit tender. So you might do a scan to see a diffuse increased uptake, which is characteristic of Graves', or maybe no uptake, which is characteristic of subacute thyroiditis, or maybe uptake which is localized to a nodule, which is typical of an autonomous functioning thyroid nodule. Rarely do neck ultrasonography in this circumstance. Of course, if you've got a clinical nodule, it's helpful, it can be. If you do colour flow Doppler, which is pretty much routine on ultrasounds, you see a very high blood flow going through the whole gland in Graves' disease. It can be quite dramatic to see it in cine, because you see the sort of thyroid maelstrom of all the blood pounding around, because the blood circulation to the full-blown hyperthyroidism can be 6 times normal. So it can be a lot of blood going through the thyroid. And of course, as we know, we're taught, if you listen to the thyroid, you can hear the sound of it, the bruit by putting the stethoscope on the thyroid. So it can be quite, and if you can hear that, you've got a diagnosis of Graves' disease. You don't need to do scans, because you know what, as long as there's no great big nodule there, then it's which is not typical of Graves'. So the short answer is sort of yes, but it's always good to have a clinical understanding of what's going on, as well as just saying, well, here's a blood test. Sometimes the blood test is wrongly labelled. One of us be careful. Sometimes things are wrong. If you're uncertain, repeat the test. Get another separate blood test.
Can you actually be negative for thyroid-stimulating hormone receptor antibodies and still have Graves' disease?
It depends on the quality of the commercial assay. Commercial assays are very good, but like all assays, there's a sensitivity, and maybe 5% or a bit less in some of the assays can be negative, even though the antibody's there. Very important research studies done in the 90s showed that if you get fresh thyroid slices from people having thyroid surgery for some other reason, you get the normal part of the thyroid, and it's stimulated with Graves' serum, 100% are positive. So you've got a fresh thyroid slice and you're measuring cyclic AMP generation. It's not a practical clinical test, but a very important research tool for the investigation. So I think the answer is that all Graves have an antibody there, but in the commercial assays, you might not always detect it.
Duncan, would you have loved Travis as one of your students in the lecture hall with those questions he's throwing at you?
Oh, they're very good questions. I mean, they're fundamental questions to understanding Graves' disease. Absolutely, yeah.
All right, we'll throw some more at you. Now, because you've said autoimmune, what other conditions do patients with Graves at risk of?
Basically, many other autoimmune conditions, organ-specific autoimmune diseases. Graves is one of them. So we think of a thing called the thyrogastric cluster. This was a big thing that was taught in the 1960s or so, where autoimmune gastritis, which can be associated with B12 deficiency, that was particularly with hypothyroidism, but I don't think there's any reason why it wouldn't exist with Graves. It does. Celiac disease, vitiligo, alopecia areata is another autoimmune disease of the skin. And of course, a young woman comes along, they can lose a bit of hair generally with overactive thyroid, but when they have area, it's very distressing to see this for them, and it can be an immune disease which is associated. But Addison's disease, type 1 diabetes, Sjogren's disease, and then less specific in terms of the immunology, but specific in terms of what happens, like lupus and rheumatoid arthritis. So across the whole spectrum, some particularly, as I said, like the thyrogastric cluster, other the association is less tight, but it's still there. So it's all autoimmune disease.
Do we know why women are more affected than men with these conditions?
I don't. It's true of all autoimmunity. There's immunity is genetic component. There's immune dysregulation. Of course, in women, they're going to get pregnant, and that's going to distort immune function. Maybe the role of estrogen, although I'm not sure that's really been pinned down very precisely. So I think the short answer is it's part of autoimmunity. Women get more autoimmune disease than men, but the precise effects on immunoregulation, I think are still, to my mind, not absolutely established.
Now, can children get Graves' disease, and does the presentation differ from adults?
Well, yes, they do. It's very uncommon, even rare, less than 5 years old, 1 in a million, increases so that there's a reasonable rate in adolescents, so in teenagers. And I guess the presentation, in principle, it's the same, but it may not be recognised because a child may not describe the symptoms very clearly, and so it may be manifest as a behavioural problem. Their mood changes, variation. Gee, that would be easy to detect in a teenager,
Yes.
of course. Yes. Mental concentration deteriorates, deteriorating school performance. I think sometimes, they've got ADHD, which is a very fashionable diagnosis. So it's a matter of thinking about those things and then saying, well, maybe there's some other physical cause. And I think people who are assessing those sorts of things will look for thyroid disease as well. In very small children, accelerated growth and advancement in bone age, and in fact, in children under the age of 5, there's a concern about accelerated closure of the cranial sutures, so the craniosynostosis. That's, I think, very rare. In paediatric endocrine practice, that's one of the issues where the paediatrician has to control very precisely the use of thyroid hormone in children that are hypothyroid to make sure they don't overtreat them. So the dose is adjusted with age and weight to be very precise and to make sure that doesn't occur. But children get it, and the manifestations can be different. Yeah.
And there is an increased risk of children who have Down syndrome. Do we know why they have an increased risk of thyroid disease?
Yeah. Well, Down syndrome is particularly associated more with Hashimoto's and hypothyroidism, but hyperthyroidism is also described. And again, they have more organ-specific autoimmune disease and more type 1 diabetes, more celiac disease. And I think the trisomy of the 21 chromosome does cause upregulation of immune response genes, so you can have more interferon receptors and more immune activation. That's as close as I can describe it. It's an immune problem in children with Down's syndrome.
Let's just take a pause for one moment, and hopefully Travis will leave your lecture hall for a break, Duncan, and we'll resume in a moment to continue our discussion. We continue our discussion now with Professor Duncan Topliss as we turn our attention towards some of the treatment and the management of patients with Graves' disease. Let's start with treatment options. What options are available for patients with Graves' disease?
As has been the case for over 60 years, there are three basic options: antithyroid drugs, a radioactive iodine therapy, or surgery, so thyroidectomy. And I guess you could say over this time, although there's been no new therapies, we have improved diagnosis and knowledge of the natural history, so our treatment selection is better. But we're now beginning to assess new immune therapies. These are now going into trial, so they're not in routine clinical use, and I guess it'll be some time before they are, but there are trials looking at agents which may be able to influence the basic underlying immune problems. And some of these drugs are being used in other immune diseases already, like multiple sclerosis, but they're going to be evaluated in Graves' and in Graves' eye disease, thyroid eye disease, to see if they're helpful. But at the moment, what we've got are antithyroid drugs. That's carbimazole and propylthiouracil, or PTU in Australia. These are inhibitors of the thyroid peroxidase, the synthetic enzyme. So they basically take the thyroid out of gear. It may be being overdriven still by the antibody, but it's not, the thyroid's not able to produce as much thyroid hormone. Radioactive iodine and thyroidectomy, of course, are ablative. If we choose surgery, we recommend now total thyroidectomy because the rate of recurrence, if you do subtotal thyroidectomy, this was very common years ago, there's a rate of recurrence. So what you get, it swings and roundabouts. You get, you obviously, by leaving some thyroid in, they don't have to take thyroid hormone, at least for a while, but there is a rate of recurrence because that little bit of thyroid can get overstimulated and recur. And that little bit of thyroid left behind can actually be destroyed by immune processes. So there is a rate of development of hypothyroidism. So the general view of surgeons, endocrinologists, is that if you're going to have surgery, have the whole thyroid out. It's end of story. You've got to take thyroid hormone for the rest of your life. That's a disadvantage. But once we've got the dose right, it's pretty stable. So that's surgery. Radioactive iodine is an outpatient treatment. It's a capsule that's swallowed containing a certain amount of radioactivity, radioiodine, which is ordered, comes in Australia, comes down from Lucas Heights and administered to the patient. It's an outpatient treatment at the sort of doses we use to treat people with overactive thyroid, so people can go home on the tram afterwards, and they're not glowing in the dark, as I tell them, and there is some excretion into urine and sweat, so there's some precautions for people to take for a week afterwards, but they're very minor. Someone who's, say a kindergarten teacher, we'd give them a week off, sort of thing. So, but this is more a principle of not exposing people unnecessarily, but it's a very, very low rate of exposure to the community. It's basically trivial. The only circumstance where it's important, I'd say, is if you're flying overseas, the radiation detectors they have in airports, for terrorism alerts, particularly in the USA, can pick up extremely minute quantities of it. So everybody that has radioactive iodine, the nuclear medicine physicians give them a little note that says they got such and such on such and such day. And I certainly had a patient that flew into Los Angeles airport and was promptly surrounded by gentlemen who escorted him and his wife off, and he sort of said, "Is this anything to do with my thyroid?" and produced this thing, and they read it and said, "Oh, I see," and they checked his thyroid out and said, "Oh, yes, fine, off you go," and he got out of the airport very quickly, but he was certainly picked up as he was walking through to customs and immigration. So that's something, but that's not a clinical issue. It's just, I guess, an issue of that we need to let people know about. So radioactive iodine can restore euthyroidism, but about 75% of people need one dose, so there are need for further doses in some people, and there is a long-term rate of hypothyroidism. So if you have radioiodine, you have to be monitored long-term for the possible development of hypothyroidism. Of course, if you give it up, you'll knock the thyroid out. But those are the three modalities we have available to us right at the moment.
Is there any one of them that is the best, or is there better evidence for some or the others, or which is?
I think they're all effective. And it really is a matter of looking at the patient and their circumstances. And it's a matter also of talking to the patient about what they think would suit them, because this is a circumstance where, I mean, there will be people can have views, and you need to provide them with the evidence. But sometimes people will say, "I couldn't possibly bear the thought of having surgery," or "Oh, radioactivity, oh no," and they may decide they're just not going to do it. And that's in the end, if that's their decision, then one respects that decision, of course. But I mean, you have to look at what the advantages and disadvantages of anti-thyroid drugs. I mean, they're simple, effective. There's no intrinsic risk of inducing hypothyroidism, and they can be used despite comorbidities in virtually all patients. So that's all good. But anti-thyroid drugs, very low incidence of itch or rash, very, very low incidence of agranulocytosis. You have to stop the drug completely. They can't have it again. The problem with anti-thyroid drugs is they generally only work while you're taking them, so there's a risk of relapse. We hope the immune condition dies down so we can stop it, which is, of course, the principle of the course of anti-thyroid drugs. But I'd say, having practiced in this area now for well over 40 years, dose adjustments and titration is not always easy. And of course, it all depends on the patient adherence to the treatment. I mean, drugs don't work if you don't take them, and sometimes people decide not to take them or forget them, etc. So that's that. Radioactive iodine is advantages. It's generally effective. It always substantially reduces the risk of recurrence. It's very safe, and of course, it's ambulatory, non-operative. But of course, it takes a while to work. If you've got Graves' eye disease, it can make it worse, so it may be a reason not to do it. You may need more than one dose. And of course, a woman that wants to get pregnant or might get pregnant, you shouldn't get pregnant within 6 months of a dose of radioiodine. And of course, if you are pregnant or breastfeeding, you can't have it then. And if you want to get pregnant, you can't have it. And if you can't comply with safety guidelines, which not so important when it's low dose, but there are some issues there. People have got to take some precautions for a short period of time afterwards. And sometimes even in Graves' disease, the uptake, maybe because it's been confounded by iodine intake, may be low, and you can't get enough iodine into the thyroid, at least at that time. So that's that. Then you turn to surgery, and the benefit of surgery is, of course, there's no risk of relapse if you have a total thyroidectomy, so that's great. There's a low risk of relapse if you have subtotal, but we don't recommend that. And it's rapid. So you get restoration of euthyroidism obviously quite promptly. We generally start people on thyroid hormone very soon afterwards. I mean, the rate of thyroid hormone fall generally people are all controlled before they go to surgery with anti-thyroid drugs. I mean, that's almost universal. So they will start on thyroid hormone, the day after surgery in vast majority of cases. So you need a good surgeon, and there are many of people who specialise in head and neck surgeons, thyroid endocrine surgeons. So it is possible to get excellent surgery in Australia. There is, of course, a low rate of something going wrong in surgery, but that's pretty low in our medical system. Has been known though. There is a risk of laryngeal nerve damage, which is very low. In Graves' disease, in good hands, can be zero in big studies, but less than 1% anyway. Sometimes there is temporary impairment, which will recover quite quickly within a month or two. And there is a rate of permanent vocal cord palsy, but that's more in complicated thyroid surgery with big, difficult glands, I think. Hyperthyroidism, temporary, is occasional. Permanent, very rare in this circumstance. And of course, people need to accept they're going to have to take lifelong thyroid hormone afterwards. So there are a few people who can't have surgery, of course, because of severe cardiopulmonary disease, but our anaesthetists are very good at getting people through surgery, even with major disease. You can't do it in pregnancy, not in the first trimester and not in the last trimester, because it can induce fetal loss or premature labour. Occasionally, it can be done in the second trimester if you're absolutely stuck for other treatments. And then it's a matter of principles. We generally would not want to take a thyroid or knock it out first time round. But if we know someone's got a great big thyroid with a brewery and it's severe hyperthyroidism and they've got very high antibodies, the chances of them getting a remission, sustained remission, are pretty low. So you might say, well, we'll control it, we'll see how well it goes, and if things go well, we can watch and wait, control. But you'd be talking to the people like that and saying, look, we'll obviously want to make you feel better by controlling you with antithyroid drugs, but you're probably going to need to choose an ablative therapy, either surgery or radioactive iodine, early on, rather than just disappearing off and hoping for the best.
Does the treatment change for children?
Well, not many surgeons want to operate on small children, right? So I guess you could do it in adolescents, but again, we're a bit more reluctant, I guess. We're also a bit reluctant to give radioactive iodine in children, although there is data from big paediatric centres that this is safe and does not have a known evidence to induce, say, malignancy, etc., which is always the worry with radioactivity. But in general, we treat with antithyroid drugs in children and maybe long-term antithyroid drugs and hope that they might go into remission. But in fact, many of them do end up having to have ablative therapy. But maybe that can be delayed into when they're bigger, they've got a bigger thyroid, they're almost adult size, and so or it can be done in early adulthood. But some of them will escape having the need to have ablative therapy.
What's the treatment of choice in pregnant patients then?
Well, no radioiodine. Pregnancy means that you, as I say, you can't operate in the first and third trimester. So you generally use antithyroid drug therapy. And the choice there is interesting because we now recognise that antithyroid drug therapy has an issue for perhaps fetal malformation. Of course, fetal malformation is slightly increased in people who are hyperthyroid. So, but it seems to be, it's that first trimester that's critical, of course, and PTU is safer than carbimazole or in the first trimester. So we would generally switch people who are planning pregnancy to PTU and keep them on PTU during the first trimester and then change them over to carbimazole. It's a bit tricky as whether you can get all this done, but that's the principal recommendation, the guidelines. The idea of not using PTU all the time is that PTU has a higher rate of liver disease than carbimazole. So it's not such a safe drug as a routine therapy. And in general, PTU has to be taken twice daily, whereas you can get carbimazole down in maintenance to a single daily dose. So it's a more convenient drug that enhances adherence to therapy. And the other issue in pregnancy, of course, is in Graves, the mother is making antibody. That antibody can pass across the placenta to stimulate the child's thyroid. So the fetus develops the thyroid by functioning thyroid by about 20 weeks of gestation. So, and very high levels of maternal antibody can stimulate the child's or fetus's embryo's thyroid. So children can be born with neonatal hyperthyroidism. Now, that's not due to their own thyroid or their own immune system, it's due to the maternal antibody. But it will pass off. But that's a condition where if the mother's got that condition, then we can have a look at the level of antibody. That tells us what the risk is, because most women with Graves are not going to have a child with neonatal hyperthyroidism, but a small percentage will. And if it's recognised at birth, so seen by a paediatrician or paediatric endocrinologist, the tests are done, it's treated with low doses of antithyroid drug therapy, and that can be weaned and ceased after a few months. So, but it's an area of particular expertise for, I guess, pediatricians, pediatric endocrinologists. The main thing is, the child is often born a bit scrawny. They may have a little goiter, and they will not thrive unless it's treated, recognised.
So when people are going through antithyroid medication or radioactive thiodine, are you monitoring their blood test to see TSH, T3, T4?
Yeah, absolutely. Yes, that's right. I mean, when we start people on antithyroid drugs, we pick a dose based upon their size and the severity of the hyperthyroidism, and we start that. So that's the initiating dose, the controlling dose, And we would obviously want to check to see if that's enough, or maybe it's too much. But and we do that at 2 to 4 weeks. Usually, I do, if it's a sort of standard circumstance and people are pretty well, about 3 weeks, and then we would adjust the dose depending upon the response. So and we continue monitoring. So you can, if everything is going along smoothly, you can decrease the frequency. I would rarely go below every 3 months, but generally I would stick to sort of 6 weeks, 6 to 8 weeks check of thyroid function tests to make sure that it's not proving excessive, etc. So that I would do that through the course of an anti-thyroid drug treatment. And in general, our course is, I mean, it's established by sort of clinical wisdom over many years, but it also turns out to be true in trials that you need to give people a course of about 12 to 18 months of anti-thyroid drug therapy, mainly maybe only at a maintenance dose, which might be 1 or 2 tablets a day. The carbimazole, which is 5 to 10 milligram. But if you stop early, there's a higher relapse rate. Whether the anti-thyroid drug has an immune effect is not clear. There is some data to support that, but it's probably more a matter of allowing the underlying immune disturbance to just settle down while they're on anti-thyroid drugs, and then you can stop. But you need to keep monitoring, and you can also look at the level of the antibody. I mean, if at the end of a course the antibody is still there, the chances of relapse are high. If at the end of the course the antibody's gone away, the risk of relapse is not zero, but it's much less because the antibody may have settled down. It could come back again. But antibody persistence at the end of a course, you might still choose to stop, but if they seem very well controlled and the patient wants to see what's happened, but you would monitor them very carefully. So when I stop anti-thyroid drugs, I check at 1 month, and if it's all right, then I go to further 2 months, 4 months, 6 months. And I always recommend that people should have a check, even if they feel well, once a year for their thyroid status. Because some people with Graves' disease can actually become hypothyroid, even though they've not had surgery, obviously, or radioactive iodine. It's part of the natural history in a small percentage. Some studies suggest even up to 10%, but I think my experience is a bit less than that. But you certainly need to monitor people for development of hypothyroidism, not just recurrent hyperthyroidism.
Where do you put the money on with regards to monitoring? Like, is that TSH? Is TSH the marker?
Well, early on, of course, TSH is suppressed, so it won't pick up for a while. So when you're monitoring early treatment, you need to look at what's happening to T4 and T3. When you are looking longer term, well, I always do a T4 as well. You've got to tell the lab that it's justified because that's a person who's got or had great thyroid disease, or they're on treatment. I would do T4 and TSH. But yeah, I mean, clearly TSH in a sense, after the TSH is recovered is the best test because it's the most sensitive. If TSH is normal, you're not hyperthyroid, and if it's not high, you're not hypothyroid either. Yeah. So it's the best long-term test. It's the best long-term test for monitoring hypothyroidism as well. But even in that circumstance, I like to do a T4 as well. But the thing about remembering, if someone's on thyroid hormone, you should always do the test pre-dose because T4 can blip up for a few hours after you give a dose, and that's not a reflection of their overall state. So either 6 hours afterwards or immediately before they take their tablets on that day when it's a thyroid hormone medication.
Are glucocorticosteroids useful at all?
Not in routine treatment of standard Graves as an outpatient. People that have got thyroid storm or imminent thyroid storm, very sick, very unwell, will need to be admitted. They're going to be treated with aggressive therapy, high-dose anti-thyroid drug therapy, high-dose iodine after the anti-thyroid drug, high-dose, highly potent steroid therapy, dexamethasone, will be used to decrease the conversion of T4 to T3 and improve the progression. I mean, in principle, of course, that sort of drug could treat Graves' disease, but it's a bit of a blunderbuss. I mean, I think we've got, you probably need high doses for a fair while, and the side effects of that are not regarded as appropriate when you've got anti-thyroid drugs which don't have any of those side effects and are very safe. So this is why we're looking at other immune therapies, which is what's coming on the market, into trials now, which may turn out to be may turn out to be a game changer, or may have turn out to have a significant place in the treatment of Graves' disease. But at the moment, they're not available to us. But we hope that they will be part of the treatment in the future, because we do need more options for the treatment.
Is weight gain an issue after treatment?
Yes. People are often very upset about this. Now, of course, some weight gain is good because you've lost weight, so you're going to restore normal weight. But there seems to be in a lot of people a bit of an overshoot. So first thing is, because you've got to explain to people you are going to put on weight because you've lost weight. So that's natural. You're going to put muscle back on. You want that. That's good. But I think what happens is there's a bit of a resetting of our appetite and resting energy expenditure, and it can take 1 to 2 years, I think, for this to work its way through the system. So there are quite a few people that do experience a little bit of overshoot of their weight, and of course they are unhappy about that. So I think it's important to advise people about that it's good to restore their weight, but they're going to need to watch their diet more carefully, and that there might be a problem. But in general, it is not something that's going to go on indefinitely, and it will correct. But they should be aware of this and be more cautious in their dietary, or monitor their dietary intake more carefully.
I am going to borrow that phrase, a little bit of overshot in my weight, just to get me some extra cover as I start trying to lose some. In closing, Professor Topliss, are there any final thoughts or advice you've got for doctors or patients about Graves' disease?
Well, it's very treatable. We do require careful individual treatment selection and monitoring, which we've really gone through, I think, in these talks. People need to adhere to their treatment, and they need to see their doctor to help get the test done and have medical adjustment of treatment. But as with all chronic conditions, the patient's involvement and understanding of what's going on, engagement in the treatment is very important. And I guess finally, just to emphasise, I think if we do get newer immunological treatments, that'll be really great. But at the moment, we're stuck with what we've got, and we can use those wisely.
Professor Duncan Topliss, thank you very much for joining us again on This Medical Life.
Pleasure. Thank you.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.